Welcome everyone. Thanks for taking the time out to be with us today for our webinar on TBS Osteo 3.1 All-in-One. Over the past several years, Medimaps has developed innovative technology, demonstrated and published clinical efficacy, received regulatory approval, strengthened its network of distributors and partners around the world, and most importantly, gained a worldwide acceptance as standard of care. We are humbled by the worldwide acceptance of our product, and that has also enabled us to continuously strive for research and new developments. TBS Osteo 3.1 All-in-One is an outcome of these efforts and a major milestone in the journey of TBS Osteo and Medimaps. In this webinar today, we will cover the scientific, clinical, and technical aspects of TBS Osteo 3.1. Let me go ahead and introduce our speakers for the day. Dr. Didier Hans. He's the head of research and development, co-director of the Center for Bone Disease, Bone and Joint Department at Lausanne University Hospital and University of Lausanne, Switzerland. Dr. Hans is also the past president of the International Society for Clinical Densitometry. Dr. Shelley Horn. She is the Chief Business Development Officer at Medimaps Group. Dr. Horn leads Medimaps' global investor acquisition and development activities and supports the development and implementation of growth opportunities. Before I request Dr. Hans to start the presentation, a little bit of housekeeping. During the webinar, I request all of you to continue to pour in your questions through the Q&A button. Without further ado, I request Dr. Hans to kindly begin with his presentation.
Oops. All right, thank you very much for this nice introduction. So thank you all of you to join this webinar in the middle of the afternoon when I know it's a beautiful day out there. So I know it's like a tricky decision whether or not you have to listen to me and my colleagues or go outside and enjoy the nice weather. So thank you for being there.
Yes, but it's also in the morning here.
So yeah, but still nice. Nevertheless, I will cover prime time for clinical practice. Are we yet there or not? So try to go towards how can we use TBS in clinical practice, whether or not we have sufficient level of evidence, and how we use it in the SHUV in the center of bone disease. So you all know that slide. So many of the slides not completely new. It's just we're putting things in a context. Osteoporosis, we know that for more than 20 years, that is characterized by low bone mass and deterioration of bone microarchitecture, leading to fracture or at least an unacceptable risk of fracture. So you can clearly see like a two type of bone, and you can see the density of the bone to some extent, but also the structure of the bone is quite different. Having said that, so WHO defined osteoporosis as a classification of osteoporosis according to T-score based on density. And you all know that if you're above -1, you'll be considered as normal. Between -2.5 and -1, you consider as osteopenic. And if you are below equal to -2.5, then you consider as osteoporotic. So where we've been using that for the last 25 years, the problem is we still see that about 40 to 50% of the major aspect fracture occurred in a non-osteoporotic zone, meaning either osteopenic or normal, meaning we mischaracterize those patients in that zone while they could benefit from treatment. So why that? Actually, we know already from the beginning that density is not the only parameters. So not having only the density, we need the second part of the WHO definition, which is bone microstructure, because you can have the same density, but different underlying structure that where the TBS can bring some additional information. So this is TBS stands for trabecular bone score. It's a texture parameter that is strongly correlated to bone microarchitecture, and this independently of bone density. So you could have two different patients here that will have almost identical density, but the underlying structure could be quite different. You could have a good structure, in that case the TBS will be fairly high, or you could have a poor structure. In that case, the TBS will be low. So a lot of studies have been demonstrated from cadaver or bone biopsy that the correlation with bone microstructure, like a 3D parameters like trabecular thickness, trabecular space, trabecular number, strut moment index, and so on, have been highly correlated to TBS, comforting the message of relationship between the TBS and bone microstructure. So now, you heard from pretty many years, there is an extensive clinical validation. Actually, the beauty of TBS is you can retrospectively analyze the past. So as such, all big prospective study, longitudinal study, cross-sectional studies can be reanalyzed very easily. And that's why there is already more than 600 publications and already more than 20 international and national guidelines about the use of TBS. But a lot of these guidelines are mostly general guidelines saying you can use it for fracture prediction, you can use it to fine-tune the level of risk and so on, but they don't tell you much about how to use it practically. Nevertheless, the bottom line is it comes from all these guidelines and publication that TBS is a fracture predictor, which is independent of BMD and clinical risk factors and FRAX. And that's very important because if you have a factor that just show you the same thing, then it's useless. You have to have an independent contribution to the overall model so that we can better fine-tune the level of risk for a patient in the assessment. And that's exactly what has been demonstrated. It will help to fine-tune the assessment of fracture risk and medical decision both in men and women, and mostly in gray zone. When we talk about gray zone, we talk about osteopenic patient, where we miss most of the patient, secondary osteoporosis, such as diabetic patient, glucocorticoid-induced osteoporosis, rheumatoid arthritis, CKD, hyperparathyroidism, and some others. Osteoarthritic patients is quite interesting because the density has been over-evaluated, overestimated in patients with arthritis, especially when you start to see around the age of 65, the BMD tend to go up again with age because of osteophyte and so on, while TBS will be minimally impacted by that. And when we talk about FRAX, obviously it will not change the whole FRAX value, but will mostly change those who are close to the intervention threshold, and I will come back to that. Another very interesting point is that there is a different treatment will impact TBS differently. So you will see where we'll put all this together, how we'll put that into the clinical context, and we'll come back to that. I will just cherry pick some of those statements here, just to back up my saying. So the biggest study that had been published in 2011 and then published with even larger numbers of patients in 2014 was from Manitoba. You all know that slide. So now if we combine these as a minimum T-score at the spine or hip, according to WHO definition, and we also have a TBS as a tertile, then several things here are very interesting. First one, you say, well, if I have an osteoporotic patient with a very low TBS, well, the level of risk is extremely high here. The incidence of fracture in that category is very important compared to the others. So first point, which is quite interesting, especially if you want to go towards strong treatment and you want to have a cluster patient for which you may try anabolic or something like that, or romosozumab or PTH and so on. Now the opposite category is also very interesting. If you have osteoporotic and a low TBS value here, then the level of risk is extremely high, while the opposite, if you have normal BMD and normal TBS, is extremely low. But the most interesting could be those two orange bars here, because the fact that you have osteoporosis with a normal value, the level of risk is not better than if you have osteopenic patient with low TBS. In other words, we're going to treat those patients on the basis of BMD, but today we're not treating those patients here, while the TBS will allow you to recapture some of the fracture that was missed. So if you look at the number of a fracture, pretty much 54% of major aspect fracture are in osteoporotic zone, 39 here in osteopenia, 7% in healthy. Now, if you combine that with the TBS, you will see that by capturing osteopenia with TBS, degraded TBS, you will recapture an additional 16%, bringing from 54 to 70%. You can even go higher if you just got this patient. And now only have 3% here if you have no bone density in TBS. So that's very interesting. Now, if I put that in another cohort, like an osteolos cohort with a 5 years prospective data here, about 115 incidents, a fairly young population starting at the age of 50. If you look at here, it's interesting to see that out of 117, only 37 of these patients were osteoporotic at the minimum of spine or hip. Then if you start to add the TBS of the very small zone, you add another 19 patients with fracture. While you can see that the orange dot is really mostly the fracture patient that put it spread around. Now, if you try to increase about the level for which you try to detect a fracture, you can recapture another 41%, bringing to a much higher value. So again, you can clearly see from that slide that using BMD alone will be a mischaracterization of your patient in terms of level of risk, and then you clearly need another layer just to improve the fracture prediction. So a lot of people say, yeah, that's why we had FRAX. And the FRAX or other clinical risk factor model. And actually, all the study I show you on Manitoba was already adjusted for clinical risk factors. And that's why the group here, the FRAX group, been publishing some data here, combining from a meta-analysis or also from a Manitoba. If you have like a highest tertile in FRAX probability and TBS, you can also see a similar trend, saying that the TBS will add something on top of the FRAX already. So that's why they developed the FRAX adjustment parameters. And if you take here the website of FRAX, when you fill up some patients here, you will see that at the end, when you calculate the fracture probability, if you have a TBS value, click here. If you click at that button, what will happen is you will have a sub-FRAX FRAX adjusted for TBS subsite, and then you will enter the TBS value, and that will recalculate the FRAX probability. So you will see here, you will move from 16 to 21 or from 3 to 4.4, which can migrate your patient from one side to the other one. So whether or not, if you have a patient in the no treatment zone here, for example, at the level of 5 or 6%, whether or not it will bring it up to a 30% zone, no way. Because you have a small incremental values. But now if you consider this zone around the intervention threshold, then about 1 patient out of 4, so 25% of the patient will migrate either above or below the intervention threshold, which is becoming quite substantial. We talk a lot about FRAX and so on, but what about T-score? So for decades, we've been using the T-score clinical practice. And yet today, we still have T-score in a lot of guidelines. And if I consider here the Swiss guideline, we still have the T-score to initiate treatment. We need for alendronate, residuronate, or the biphosphonate general, or raxifan, denosumab, teriparatide, or some others. There are some specific conditions, but they're all based on T-score and not on FRAX yet. Even though we have intervention threshold with FRAX, the reimbursement still been tied to BMD T-score in most regions of the world. So having said that, we just decided with Bill Leslie and John Canis and some few others from the FRAX group, just to apply a similar approach that what we apply for the FRAX adjustment. So the idea was, okay, we adjust the FRAX by the additional value of TBS. Now we did exactly the same by saying, okay, we'll adjust the BMD T-score by the structural information that we have through the TBS. And here we have like the odds ratio per standard deviation as a major thoracic fracture or hip fracture from the Manitoba here. And where we can see that every time we adjust the femoral neck BMD T-score or hip BMD T-score or spine BMD T-score, whether it's major thoracic fracture or hip fracture, we will improve the hazard ratio by incorporating the TBS into it. So that we start to have BMD T-score adjusted by TBS. So the way it looks like at the end is almost like the FRAX, And I will not go into too much detail about the curve, but it will tell you that, for example, if you have one patient here, depending if, for example, that patient will be 55 years old and that patient will be osteopenic, if you have a minus 1.5 here, then depending on the TBS value, either you will become normal or you may even become osteoporotic if you have a very low TBS. So that will readjust the value of the BMD T-score in order to take into account the degradation of the bone structure. So what about treatment? So we hear a lot about treatment, and I heard sometimes disappointment saying, wow, you know, I've been measuring my patient with biphosphonate, and even some guidelines say, well, it doesn't sound to be very useful monitoring patient with under biphosphonate. Is it normal or not normal? Actually, it's quite interesting because that reflects perfectly what we should expect for the mechanism of action of the different molecule. If you take here a PTH or denosumab or biphosphonate or estrogen, nothing, or GIO patient, glucocorticoid or anti-aromatase, the impact on the density or the structure is expected to be quite different. Anabolic will have a major impact on the density and also quite impact on the structure of the bone. Denosumab more on BMD, a bit less on the structure, but still. Biphosphonate, we're supposed to have something in between where we will have what we will call a positive maintenance of the structure, while on estrogen we will have a negative maintenance of the structure, meaning slowing down the potential loss as we will observe in a normal patient with a normal bone loss. Now, glucocorticoid or anti-aromatase will have almost more impact on the structure of the bone than it is on a BMD. So if we expect by the mechanism of action different impact on density and the bone microstructure, that's normal that we will also expect different effect on BMD and TBS, as we'll be able to see on the next slide. So by summarizing that on one slide from different studies, and there is currently an ongoing systematic review on treatment that will be coming out this year, hopefully, with more than 30 studies on treatment. What we have here is exactly what I told you: impact on structure from the TBS, impact on density, and depending on the molecule, you see that the profile will be quite different. So when you start to think about profile, say different profile, different molecule, let's start to connect the dots and then start to wonder, maybe I could use that in a certain value. Now, having said that, the fact if you're under treatment, but you're still losing TBS, even biphosphonate, for example, if you're under biphosphonate, but you're losing TBS during the same period of time, then you will increase your level of risk, irrespectively of the increase of the density, and you should take that into account. So now if we combine all the knowledge of the fracture production, secondary osteoporosis, impact of treatment, the fracture adjusted, and the BMD T-score, we put that together into a daily practice, then that's the way it looks like. And I will be a bit provocative, but try to apply a certain clinical logic. So if you see the logo, it'd be mostly personal, so not only mine, actually my PhD student working on it, and she's currently finalizing the writing of her thesis that will be submitted in 2 weeks. That's come also from the work with her. So what we have is the classical 6 steps. The first is you will check the image, you will characterize your patient, you will characterize the bone profile of your patient, wonder whether or not you should treat your patient, start to ask yourself which kind of treatment, and then after it be mostly monitoring. So the check image quality, obviously what's applied for BMD image is the same for TBS, in the sense that the garbage in, garbage out concept is still valid. If you do a bad spine and a bad edge detection and so on, if you include an artifact in it, then that will have an impact on TBS. So obviously, as I said before, the osteoarthritis will impact much more the spine BMD rather than the TBS. But reversely, we may have a bit more impact of soft tissue on the TBS than it is on the BMD, even both of them are influenced by soft tissue. So we will have to check first that the image has been correctly acquired and that there is no major artifact visible on the image. The second is to use the threshold of 131 and 123 to characterize the level of structure compared to reference curve, whether or not your patient is normal structure or partially degraded structure or degraded structure, as for normal osteopenic and osteoporotic. So by combining those with the BMD, you start to have here what I call the bone health category with a certain level of risk. It's like the same like the 3D graph I showed you at the beginning. If you have osteoporosis at the minimum T-score and the degraded TBS, your level of risk is very high compared to osteoporotic here and or osteopenic with partially degraded TBS. Then the orange rose is a high risk and should be considered. And the green one is lower risk, and the TBS, a dark green is lowest risk of fracture. So if you have a patient here, you should ask yourself, is that normal for the age? If there is a known secondary osteoporosis cause, if there is undiagnosed vertebral fracture, then maybe I should trigger some additional exam, either VFA or maybe an X-ray or something like that. Any prevalent of mesotic fracture, maybe that the patient forget to mention to you. If there's unknown pre or diabetics, that's very important because in diabetic, what's been shown that if you have a type 2 diabetic patient with either not diagnosed yet or pre-diabetic stage, that the structure of the bone will be degraded, unlike the BMD, which will be pretty much normal or supernormal. Now, if you've been diagnosed, but the glycemic level not been controlled, meaning above 7.5, then it will mean that the structure still be degraded. Now, if you have a glycemic level that is controlled, then those patients will have a normal structure. So that's why in the literature, we see different type of results about TBS in diabetic patients. If you have a normal controlled diabetic patient, then the structure is supposed to be normal. It's only if it's not controlled for glycemic level that you should have degraded structure. Nevertheless, you characterize that. But then the next question is, should I treat my patients? Because a lot of patients say, oh, well, or doctors or colleagues will say, well, Didier, that's very nice. You have a high risk here, but you know what? We cannot treat the patient because either we need FRAX or we need the BMD T-score one way or another. That's a good point. So for us, there is two options. If you're low here, then either you have the option one just to use the FRAX and you will the FRAX adjusted by TBS. So you will see here, based on the risk adjusted by TBS, whether or not that value is above the intervention threshold of your the national guideline for your given country. For example, in Switzerland, we have certain threshold as an age dependent. So if we are above or below, then you will optimize the treatment or not, depending, as this has been published here by the IOF working group. So in other words, if you're osteopenic and then you have a low TBS, and then it's adjusted risk for TBS as a FRAX is above intervention threshold, then you will be able to treat your patients. The other option is something slightly different, will be the BMD T-score, because what's important, FRAX will tell you who to treat, but not for say how to treat. And that's a bit tricky because here you have the truth. You always wonder which truth, and both angle will be right, depending on the perspective you put yourself. So the FRAX is pretty much the same because a given FRAX value could have different etiology to some extent, different origin. It could be clinical related, clinical factor related, or it could be bone related, which could be quality or quantity related. So depending the origin of the value, obviously if you have a clinical risk factors related probability above the intervention threshold, then the way you will treat your patient will be completely different as it is bone related, because you know you can impact the bone related factors, but you may not impact the clinical risk factors. For example, history of a family history of hip fracture. Whatever you do, it's still your family. You will not be, it's not because you signed a discharge that it's not your family anymore. So you still be at risk based on something that you cannot reverse. So that's very important. That's why knowing how the structure and the density is done will give you some more insightful information about how to handle your patient. So the option 2 will be to use the BMD T-score adjusted. And if you have here, for example, a patient that was osteopenic, but for which we had a low TBS, then the adjusted BMD T-score might be minus 2.6. It will be an equivalent of a compatible with an osteoporosis. And that's where we could potentially take that information and decide to treat the patient, because we know that the level of risk is high, that potentially you're above the intervention threshold or not from FRAX, and then the BMD T-score adjusted is below the minus 2.5 as defined by WHO. So this is just give you an example of our BMD bone health, let's say, example from the Center of Bone Disease in my hospital. So where we have here all the BMD value, we have also the TBS, we have a VFA, then we have a page with all the image. And then on the last page, we have like the category of risk based on BMD T-score. About here are the BMD T-score adjusted, the FRAX adjusted, the intervention threshold for Switzerland, and then we have the conclusions. So that's the way we're going to use in clinical practice for us to move forward. We're going to use both options, the FRAX adjusted plus the BMD T-score adjusted, to have a more precise diagnostic and a better management for patients. Now, what about treatment? Well, this is pure speculative based on what we've seen. It's not completely speculative based on the profile of the drugs, but clearly if you have a certain profile of risk for given patients, then you see that, well, if I have here a patient which is degraded in terms of density and structure, well, I have a certain profile, and I know, for example, biphosphonate or some others will not improve the structure of the bone. So I would like to select a treatment that will improve the structure of the bone rather than just improve the density. We could do both, of course, but we could decide to increase the density only, but then you will have to treat longer, and I will come back on that on the next slide. So here, if you have an osteoporotic patient, and then the structure is fairly good, then you can give a biphosphonate or even allow yourself to lose a bit some structure. It doesn't really matter because you still have the high level of structure, so you will migrate your patient toward that. And that's quite interesting because then you can start to select a certain type of treatment compared to the type of profile, according to the profile of the patient, a type of drugs, knowing that they will impact the density and the structure differently. So finally, when we have a treatment and we follow them over the time, obviously we'll see whether or not it improve or decrease and so on. But more important, so the treat to target concept been slightly modified here to treat to lower risk zone, because at the end you don't want a single target as a minus 2.5 T-score. You want something, you want your patient get out of a high risk zone. So here will be like a treatment pathway where you want to take your patient from a high risk zone, a dark red, to orange or to yellow. Why not green? Is because most of the time the patient already had, for example, a fracture, and then the fracture still provide a residual risk. So you cannot remove completely. So that's why you just have to adapt the treatment, but keep following your patients. But here it gives you an idea. If I'm here and I decide to give a PTH, for example, I will get my patient out of the high risk zone very rapidly by improving the density and the structure. If my patient say, I don't want a PTH, I want biphosphonate, okay, no problem. You can take biphosphonate, you have to improve the density, but they need to treat the patient much longer so that you get your patient out of the ISO risk zone to some extent to a high risk zone through that pathway. That means treating at the target, which will be much higher to reach. And that might be 5 years or 10 years of treatment. So that will help us just to monitor the patients. And if I go back to all monitoring report also in our site. We monitor, of course, the spine BMD, spine TBS over time, femur BMD here, so that's again fake value, but we'll, beside the percentage between visit, we also look at the trend, whether or not the patient trained to go down or increase or improve, and have a conclusion of this. So that's the way we do. So the bottom line, the take-home message is you don't treat more, you just treat better those who really are in need. And you know that many of us been mischaracterized some patient and fell into the crack and never been received treatment, while we know we can reduce their risk by 50% by giving some of the treatment. But the bottom line is also you always take into account the clinical context of your patient and trust your own judgment, because whatever guideline you will have at one point, your gut will tell you to do something else for a given patient, because you know the context. Always go along that one as well. So to answer the question asked at the beginning, is it ready for prime time clinical use? The answer is clearly yes. There is sufficient level of evidence for fracture prediction, for a frax value, for added value, with more than 600 publications and guidelines. So now the best idea is how you combine that in a clinical routine in a very intuitive manner to really help you in addressing the patient concern, and at the end is good for everybody. Okay, so I will put Shelley will be the next speaker. Maybe you can unmute Shelley. So in the meantime, I see there is some questions. So until Shelley is back and defrozen and come back, I will try to answer. So just to summarize from Taylor Theodore, there is a lot of stuff. We couldn't understand your question as a response to the question. So the question, the answer for the hip is yes, we're currently working as a research on the TBS of the hip for both DXA scans and also X-rays. We also work on, we have a nice article that just came out on TBS of the knee from X-ray and also from DXA that we published with Neil Binkley. And we also have an ongoing publication that's been submitted about TBS on the VFA from the lateral spine, and they all demonstrate fairly good results. So when will be a product that I don't know, that's so many things to be done, but that's a research, we start to see pretty nice results, okay? Now, can TBS predict fracture risk at femur? Yes, actually, that's what I've been demonstrated. The TBS predict fracture for major spec fracture, predict spine fracture, wrist fracture, hip fracture, or all linked together. So that just do quite a lot of things. It covers pretty much all type of fractures. So now the last one I can see here is, thank you, a relationship between TBS and calcaneus ultrasound. Very good questions. In osteo loss, we've been collecting and follow patients for 10 years. So we're just like in the last visit now, and we're just collecting information on TBS and also ultrasound with several types of ultrasound. I haven't done any analysis yet, so the answer is I don't know. So if someone get the answer, be curious to see that. But since ultrasound have some more impact from a structural standpoint, if you talk about the BUA, for example, then we could expect some kind of a correlation. How much will it be? I don't know. And that would be an excellent article or a study to do. So hip mainly cortical bone, so heart trabecular score. So there is two things. First of all, when we say about hip mainly cortical bone, that's true if we take the global hip, but if you take the proximal femur, then the trochanter, for example, is mainly trabecular bone. If you take the femoral neck, I agree with you, it will be cortical bone. Now, if you take the intershaft, then intertrochanter, that also mostly trabecular bone. So now if you go further down the femur, the more you go along the shaft, the more you will have cortical bone. But still, you still have some impact on TBS on the trabecular bone in the hip that can be useful. May not be as useful as we will see with the spine, but still providing some level of information.
Hello. Thank you, Professor Hans, for that great information. I think every tool is only as useful as its clinical relevance. And I think you showed us some great understanding of how to utilize TBS in a routine clinical practice and how important it is to have it in combination with BMD. And as you see right here, this is kind of the phrase that we like to use with MediMaps and how we think about TBS, because it truly exemplifies what Professor Hans just went over, which is basically, we call it I-Fi. Rather than Wi-Fi, it's I-Fi, because you identify more patients at risk, you can fine-tune the therapy decisions, and improve patient management for follow-up. So really like sort of think about it from that standpoint and what TBS does. In the sense of identifying more patients, is independent predictor of fracture, the number of international guidelines it is. So it's really, it's not something that's new. So it's been out there for quite a while. Just important that we've come up with a report that makes it so much easier to use. So we've been listening to everybody. Next slide, please. And as Professor Hans mentioned, the beauty of TBS is that it does answer the World Health Organization definition of osteoporosis, and hence the reason why we've been missing patients without it. Because with TBS and bone density, you also get the structure, which is important. This just kind of describes, we can probably move forward from this, given the time frame. It sort of describes what you went through. And the secondary osteoporosis. This is a nice slide, and I want you just to highlight this, because in addition to the different reasons why TBS is so helpful, is that one, whether or not you're on the FRAX or T-score border of whether to treat or not to treat, whether you have osteoarthritis where osteophytes are affecting it, which TBS does not affect it as much, or if you're dealing with secondary osteoporosis, we've seen that TBS is much better predictor of fracture with those who are suffering from secondary osteoporosis due to many of these conditions. And that's why it's important to do both TBS and BMD. Next slide, please. So a couple of key things before we go to the report. Things that you need to consider about using this in daily routine. It's completely within, it's very simple. It's within the normal workflow. But some conditions, we only do it on the lumbar spine right now. We do have a research product called TRIP that you can use for other regions. But the research have indicated that the lumbar spine is as much of a predictor, TBS lumbar spine is just as much of a predictor of femoral neck fractures as lumbar spine fractures. The other thing is that it's only to be used, it's only approved for adults. There are a lot of research going on with children, but those patients who are 20 years and older is what it's approved for. And of course, the BMI from 15 to 37 is what you want to be able to stay within that realm. Again, there are a lot of studies that are being done above and below that range, but that's what it's approved from. And then just the acquisition mode is important for a couple of reasons. And with the new report, one, no express mode, but that's with all of TBSs. And the other one is with the new report, if you're doing dual hip, you don't want to report it TBS with the dual hip reporting mode in the current 3.1 version. But most people aren't doing that, but I just want to highlight that. Next slide, please. So the key element of the TBS report all-in-one is, as you saw, Professor Hans went through different elements in the sense of looking at bone density, looking at TBS, considering FRAX, all the different elements. And historically, you kind of had to pull these from all different things. So you had multiple reports trying to give you the same information, which as a result of it takes a lot more time to report out to your referring base, to the referring doctors. So our all-in-one report, the 3.1 all-in-one, takes the bone density value, takes the TBS value, takes the FRAX value, both adjusted by TBS and not adjusted by TBS, as well as the T-score adjusted and not adjusted, all in one report. So it makes it so much easier now to have one report with all of the critical information required to make decisions for your patients, and particularly for radiologists to report out to the referral base. I'm going to touch on the ones that are highlighted in red because those are the most important differences that we have with this new report. Besides, of course, it having everything together, I'm going to touch on some of these key components and how they're important, particularly as Professor Hans sort of demonstrated to us of all the different ways they use it to make clinical decisions. And so we've developed the report to really kind of help guide that. So this looks at the fracture risk assessment. This takes into the consideration that large Manitoba study that Professor Hans was discussing. And how he had it as a chart, and we've put it in as sort of a graph, in essence, that takes on the top the BMD T-score, which is what we use to define osteoporosis currently. And then on the left side, you see the TBS score about degraded bone microarchitecture, whether it's degraded, partially degraded, or normal. And so on the report, this will actually be charted for you of where your patient resides. So it really allows you to very quickly and easily see the combination of BMD and TBS to define the risk fracture of the patients. We do have a link, by the way, if you wanted to get the Manitoba study, so you can go onto our website and pull that down very easily to highlight some of it. And so if you look at the therapeutic decision tools, again, that touches on the numerous elements that Professor Hans was discussing. Now, we're not going to have in here any recommendations of treating. That's completely up to the doctor based on that. But given that a lot of the decisions are based on FRAX or on the T-score, we have both of them calculated in here for the not adjusted and the adjusted by TBS. So you have all the elements there. And what it'll do is it'll highlight that one when you take all the elements into consideration of the highest risk in the combination of them to give indications as to where the patient is. So as Professor Hans mentioned, that the nice thing about this is that, particularly with FRAX, you see a lot of patients who might be on the threshold, whether to treat or not to treat. And the TBS adjusted can really help guide with that. And I've talked to many clinicians who have indicated that indeed the TBS helps them make that decision because they do see a lot of patients on the threshold and they use the TBS to guide them to make any additional decisions on that. The BMD adjusted T-score, the same concept. Now you don't use both of them. You don't take the T-score from the BMD adjusted and play it into FRAX. It doesn't work that way. You either use the FRAX adjusted or the TBS adjusted T-score. But we provide both information because depending on your local guidelines might suggest one or the other. So we wanted to provide both of them. You can turn one or the other off if you prefer not to have both of them presented, if it may feel that it's not within your guidelines and therefore you don't want to present it to your referring base. So you have that option. But if you want to give your referring base all the information possible, this would be a good way to do it. Okay, and this is a great piece. We have had so much inquiry and questions from radiologists in particular, asking for some better understanding of what they should be reporting to the referring base. So what we've done is with the help of international medical societies and community, guide us into developing some recommended conclusions. It takes all of the elements we just discussed into consideration. It takes the fracture risk grid. It considers the FRAX adjusted or not adjusted. It considers the TBS adjusted T-score and has recommendations just in the sense of what that means from a fracture risk standpoint. But the bottom line is, of course, is to use the information in context with your local guidelines and recommendations for treatment. You can edit these. They are done at the time of the report completion. So we do have some who have decided that they want to maybe modify it ever so slightly, and they're incorporating that into their final reporting. So as you can see here, maybe the wording is something you would prefer to have it slightly different, or you want to take a piece of it out. They are editable conclusions, but these were based on medical society guidelines as well as experts in the field to help us define them. And finally, there's references of all of the elements that are part of the report on the bottom, and that's helpful for your referral base so they can understand that it comes from a significant amount of scientific clinical data. Okay, and that discusses the editable conclusions again. in following up with your patients, the nice thing we also have is we have the trending report. Now, the trending report was something we had before, which just looked at the graph, but now we actually also take into consideration the fracture risk assessment grid that looks at BMD and TBS together. So if you think about what Professor Hans was describing in the sense of treat to lower risk zone, that's where that grid really helps out. It will show you the direction that your patient is going. If the patient is started off in the osteopenic with the graded TBS and microarchitecture, it will give you an indication of whether or not it's moving in a worse direction or whether treatment is having an impact and is moving into a lower risk zone. But this helps you to see which way the direction your patient's going, if it's helping them in the sense of the fracture risk and the management of the patient and monitoring over time. So it takes all these elements into consideration, which I think is very helpful based on what Professor Hans was presenting beforehand. I think that's the last of my slides. So what I'd like to do at this point in time, and we have on our website is an actual guide that explains each section of the new report. So it goes over the same elements I just discussed. It gives you a little bit more information about some of the ones that have been in our previous reporting, but if you're new to TBS, it'll give you some information along those lines as well. It's a really, really good tool. We've had some really good feedback that people find it very helpful. So please feel free to go to our website and download this form so that it'll be able to provide you some details about how to interpret the new report for TBS. So at this time, I'd like to open up the discussion to any questions that people may have, either for Professor Hans and a lot of the information, the great information he has provided to you today, or anything specific you might have about the most up-to-date version of TBS, the version 3.1 all-in-one.
Let's see. So the first one is how I can use BMD adjusted TBS in my clinic. Does it need to buy an extra program? I will try to answer that. So the BMD T-score adjusted is embedded into the 3.1.1 or 3.1, let's say, software. So depending on the version of software do you have, either you will need to have an upgrade or you already have, you one of the lucky one and you already have it. In that case, you can use it straight away. But if you don't have it, you will need to upgrade your software from the previous version to the 3.1, or if you don't have any of them, well, you need to buy the 3.1. Okay? So that's done. So will TBS improvement predict fracture risk reduction? Well, I'm not, it depends. If you mean that whether or not with a change of TBS will contribute to fracture risk reduction, I'm not quite sure about the question. Because clearly TBS can improve the fracture risk, but fracture risk reduction, I will guess it's attached to a treatment effect. So clearly, as a TBS standalone right now, there is no study demonstrating a fracture risk reduction under treatment, because most of the studies that have been tested was anti-resorptive. So we need a very large study to do that. So if we have a study with a PTH or romosozumab or whatever, then we'll be able to answer the question. However, if you combine the TBS through the BMD T-score, then that will impact the outcome. And we know that the BMD and then BMD T-score adjusted by TBS will predict the fracture reduction under treatment. In that case, through the BMD T-score, that should most likely happening. All right. Now, how is the new 3.1 software different from integrated TBS already on the Lunar product line?
I can answer that.
Yes.
The way that it's different is two things. The Lunar product line actually is integrated within their entire software and their product. So it actually is a part of their product now. And so it has one report with all of the others. So that is a nice thing about the Lunar product line, is that indeed it's incorporated into one report, including all of the elements that go with it. what it doesn't have that the 3.1 does have is it doesn't have the actual fracture risk grid. It doesn't have the TBS adjusted T-score, although I think there's some discussion that that might be added on it soon as an ancillary. And the follow-up report, the trending report doesn't have the grid trending, which goes back to Professor Hans's thing about, you know, treating to lower risk zones. So you're monitoring how the patient's moving in the risk zone. But it does have the trending report in the graph. So those are the main differences, but both of them have, you know, tremendous value in the way that they're presenting.
There is another question that is pretty similar, is does it integrate with GSV18? So I think it's, you answer both. And I think it's, just to complete what Shelley said, not today, but toward maybe beginning of next year or toward the end of the year might be. So I know there is ongoing discussion with the GE, but it will not be available for several months at least.
Right. So the answer is not yet.
Not yet. What impact does high BMI have? Well, actually, it's like any image. If you add more soft tissue above an image, on an X-ray image, then you will have more noise in the image. And by having noise, you're adding artifactual texture to the image. So TBS been taking that into account to some extent, but obviously beyond a certain level, you cannot correct you cannot correct completely if you have really obese patients. So they tend to have a negative impact on the BMI on TBS, but the impact there is on TBS to some extent as an absolute value is less pronounced than the impact on BMI on BMD. We forget about that, but the BMD correlation with the BMI is extremely high, and it's higher than what we observe with TBS. The thing which is disturbing is that it goes in opposite direction. So that's why we recommend that we look at whether or not the patients stay within the range which is validated by Medimaps. Outside that range, we may have over estimation. We have a too high BMI, and that will reduce the level of TBS, which might be underestimate, because the correction that will be applied may not be enough. So we tend to have then lower value. Now, having said that, I said at the beginning that you have to look at the image. So it's not much the BMI which is important, but the overlying tissue thickness. And you can have a BMI of, for example, a BMI of 35, which is a common BMI in like a mild obese person. But then Arnold Schwarzenegger used to have a BMI of 35, and it's clearly not obese. So the BMI will not tell you everything. It's like mostly the mass and so on. So at the end, what is more matter is the overlying soft tissue in the region of interest, and also the way it just the morphotype, whether or not it's in the thigh or if it's over the belly, is quite different, and that will impacting differently for both, again, BMD and TBS. So some algorithm also been worked out, and part of it has been partially corrected, and down the road, more will be done along those lines. Okay. So there is no more questions, at least at this stage. Do you guys have any other question that you dare to ask, or you wanted to ask? Or Shelley, do you have any questions yourself?
No, I think that it was a good session. If anybody has any additional questions or would like to know more about the 3.1, if we didn't answer your questions because you may have had something that you were thinking differently, please don't hesitate to reach out to either of us. And otherwise, thank you so much for joining us. And thank you, Professor Hans, for your time and the great presentation.
Thank you.
Thank you, Dr. Horn. Thank you, Dr. Hans. Thank you, everybody, to join this webinar. We will be sending across a video. And as Shelley mentioned, if you have any questions, reach out to us. Thanks once again.
Thank you.
All right. Thank you, all of you. Bye-bye now.
Bye.